Thank you, Dr. Suhail. This is a really interesting subject. Brings all new things, mysteries about this drug, and now in non-diabetics. There is time for discussion. Dr. Mohammed Nassr, if you want to moderate this.
Yeah. Thanks again for Dr. Suhail and Dr. Tareq for these nice, comprehensive and informative presentations. Both of them, they talk about new or the updated informations about the DAPT and acute coronary syndrome and new medications in patients with heart failure with or without diabetes mellitus. So we start our discussion now. If there is any questions, we'll be happy to receive it.
Mike.
Dr. Tareq, shukran for the excellent presentation. I have two questions. أول شيء for patients with non-ST elevation MI. تمام. If I am following an invasive strategy, I mean my patient is admitted today with a non-ST elevation MI. I want to do cath in the next morning. Should I still preload those patients with B2Y12 inhibitors, taking in consideration that 20% of those patients will need surgery? The other question is regarding patients with elective cardiac catheterization. Is it good medicine or is it a good practice? Or is there any evidence to preload all these patients with B2Y12 inhibitors? Thank you.
For elective cases, no, there's no evidence to preload the patients. There's no evidence to preload the patients for elective cases. We can do it on the table. Regarding the guidelines, invasive approach, they define it actually within 3 hours. Within 3 hours. Within 3 hours. Like a patient's admitted 8 in the morning, you have till 11. This is what they call it invasive. They differ. Sometimes they say 12 hours. But yeah, we would preload if patients, like the next day, okay, from Friday afternoon, patients admitted with non-ST elevation MI, it's better to preload them even if the cath is the next day. I think it's less than 20%. We're talking about left main. I think we're talking about 5% patients will need CABG. It doesn't make sense to prevent 95% of the people from the benefit of dual antiplatelet therapy just for the 5% of patients who might need actually surgery. And then if they need surgery, then we'll deal with it at that time.
I guess in non-ST elevation myocardial infarction, you know that the mortality is even during the first 3 years is more than in patients with ST elevation myocardial infarction. And taking these patients with ST depression or recurrent chest pain without preloading with dual antiplatelet therapy because somebody might think that, that this guy might go to surgery, and you just think about it. How often we send patients from the cath lab to surgery? It rarely happens. It's better to take the patient loaded and overloaded actually before doing procedure.
And of course, to preload them, we can only use ticagrelor or clopidogrel, not prasugrel.
Yeah, if I...
Yeah, Dr.
Now, just to add a short comment, the question of the pretreatment on non-STEMI patient is a matter of discussion for the last 10 years, and recently we had new data also. We had the recent ISAREAC 5, which compare different drugs, but also compare different strategy. And I think it's not only the problem of surgery, I think, because we know also that sometimes we have a real non-STEMI patient, and at the end, after the angio, it will be Takotsubo syndrome, it will be myocarditis, it will be something else. So that's also, we know that even if we take patient with positive troponin, roughly half of the patient will have PCI. So meaning we will preload half of the patient with a risk of bleeding without any benefit. And we know from the ACOST study a few years ago, which compare to give P2Y12 blockers in non-STEMI before the cath lab or after the angio when we know we will do PCI, there was increase of bleeding, that's obvious, but even there was no ischemic benefit. So I think we have to be very cautious by pretreatment in non-STEMI, and when we ask, just in my practice, we have very high probability, meaning real patient with risk factor, chest pain, low bleeding risk of the patient, opinion of cardiologist, meaning never in the pre-hospital setting or just in emergency department. I think we need to have the echo, we need to have ECG, we need to take time. And also, exactly as you said, only for the patient who will have, let's say, delay invasive strategy more than 24 hours. But I think if you work in PCI center and the patient will go in the cath lab within the next few hours, I will not recommend to do pretreatment in non-STEMI. And I know that the ESC guideline will change soon, especially according to the result of ISA-REAC 5. So I think it's not never or always, but it has, I think, to be very selective.
But the ISA-REACT 5, it wasn't a double-blinded study. There are many limitations for the ISA-REACT 5. The ISA-REACT 5 compared prasugrel versus ticagrelor in patients with ACS, and it was better for prasugrel. But there are many limitations with that study. Do you think the guidelines will change based on one study?
Well, first, as doctor, and even if it's even true for the company, when we don't like the result of the study, we start saying that the study has many limitations. But still, the study has been published, I think, in good journal, yeah, which is New England Journal of Medicine, which is probably the best one. It has been presented as one of the largest meetings. So, of course, we can always discuss about the quality of the study, but at least we have today with ACOST and also ISA-REAC 5 studies with limitation showing no benefit of pretreatment, and I'm not aware of any study showing benefit of pretreatment. So I agree that the study in favor of pretreatment have some limitation, but on the other hand, we don't have study providing evidence to support the use of pretreatment as a routine strategy in non-STEMI patients.
Yes, Dr. Samir. Microphone.
Arguments are valid. The way we practice acute coronary syndrome in our region is that we have very few patients who go with non-STEMI to the cath lab with the first 24 hours. And I think we have to remind the audience that P2Y12 inhibitors and antiplatelets in general are not only antithrombotic, but they're also anti-inflammatory. And platelets activation release significant pro-inflammatory mediators. And therefore, to sit on a patient 24 hours with a suspicion of ACS without pre-treatment, I think, in the way we practice cardiology in our region, because of several factors, I think it's always better, like Tareq said, to err on the side of pre-treatment, and then you can always stop it later if the diagnosis is wrong, if it's Takotsubo, if it's surgical. But I think it's not very wise in our setup, because in Europe you take patients within 6 hours. We don't do that because of many reasons, including logistic, including financial, etc. So I think it's better to err on the side of, if I diagnose or suspect highly acute coronary syndrome, we advise that we give P2Y12 on the first encounter. And this is also articulated in the American guidelines. First encounter. So I think this is a way that suits our kind of practice.
Dr. Tareq, I have a question for you.
One short comment to that, because I'm European, I'm sorry, but also I'm working in university teaching hospital, meaning that most of these non-STEMI patients will be seen by residents or fellows or younger people. And I think for us, probably it's quite easy to have the feeling, because we have some experience, we've seen so many cases, and also we did so many mistakes that now we improved a little bit, I hope. But I still have in mind, when we use pretreatment, some aortic dissection coming with ongoing chest pain and ST changes for 10 years, and they had ticagrelor, and it was a nightmare for the surgeon. So I think as long as we don't have benefit for all the patients, I still believe that it's dangerous to do it for all. But
Dr. Tareq, for patients who are on double antiplatelet therapy, after 1 year, if there is indications to extend the DAPT, which regime you will prefer to continue on? This is one. And if you will decide to withdraw one of the antiplatelets, do you prefer to continue on aspirin or Plavix?
The literature does recommend to withdraw the P2Y2 inhibitor and continue the aspirin after that. Actually, the studies were different. Some continued to 24 months and some to 36 months. I would choose, honestly, maybe 36 months, honestly, or for that.
Which regime you will choose?
Aspirin.
I mean,
which with the P2Y2 inhibitor.
Yeah.
Yeah, it depends. The evidence is there for clopidogrel studies more. For ticagrelor, the European guidelines do recommend you can use ticagrelor, but a dose 60 milligrams instead of 90. 60. There's no evidence for the 90 milligram.
Do we have 60 milligrams?
No, in Jordan we don't have the 60 milligram. And also there's a good study that was published in the TCT 2 months ago. It's called the Twilight study, which compared actually even ACS patients were included in the trial, that after 3 months you give ticagrelor and aspirin, and after 3 months you stop the aspirin, you continue ticagrelor for up to a year. And actually the study was a very good study, that there was no risk of increased stent thrombosis.
I have a question to Dr. Tareq. Since we are in this region and we still see thrombolytic therapy giving to patients, if you face a patient given thrombolytic therapy, would you give him clopidogrel, ticagrelor, prasugrel, or you choose not? And if you choose one of them, would you load or would you not load, and what's the dose?
For fibrinolytic therapy, it's only clopidogrel we can use. It depends on the age. If the age more than 75, we don't load. If age more than 75, we don't load clopidogrel. We just give 75. If the age of the patient is less than 75, we do load only with 300 milligrams of clopidogrel, and then continue after that 75. The other P2Y2 inhibitors, so far there's no evidence to be used in fibrinolytic therapy.
We expressed surgeons' fear of doing surgery while the patient is loaded, but how often we wheel somebody from the cath lab to the surgery theater? We're doing on daily basis cath, PCI, but only rarely we wheel somebody who crashed to the surgery. Those patients are very few. Most of the time, we have enough time to discontinue the drug for 5 days, and safely the surgeon can do his surgery.
Yes.
Yeah.
Any more questions? Okay. Thank you, everybody. And this is the time for lunch.
Lunchtime, yeah.
Thank you.